Hi, it's Chris Westfall again with another update about Medicare. This is March 2021. As I record this today, some news, some studies about Medicare Advantage and the people who are greatly affected, maybe in an adverse way. I want to bring this to you because there's no one plan for everybody. You have to make a choice when you're going on Medicare, when you're turning 65. Are you going to have just original Medicare, which is great? Or are you going to have a Medicare supplement, which supplements the whole of original Medicare, which is even greater? Or are you going to give up your original Part A and Part B benefits and exchange that for a private plan known as a Medicare Advantage plan funded by the government but run by private organizations? And today we're going to look at another study that came out. It's called Rural Residents Twice as Likely to Leave Medicare Advantage as Urbanites, a study says. This is from the March 1st edition of Modern Healthcare. Incidentally, my favorite uncle ever was Uncle Bill, who lived in Louisville, Arkansas. And he used to call people in the cities, instead of urbanites, as the study says, he used to call them city slickers. So we'll use the term city slickers and rural residents to tell the difference here. In this story, it's pages and pages long. It's a really in-depth study. I just want to share with you some of the highlights and what the trends have found. It says researchers from Drexel University and Brown University, two colleges working together on the same study, they analyzed over 17,900 member responses to an annual Medicare current benefit survey to find that, a bunch of numbers here. I'll give you the bottom line in just a second. 10.5% of rural, outside the city, non-city slickers, Medicare Advantage members switched back to original Medicare, while 5% of city slickers switched from the public-private partnership to the government program. So, the report analyzed 11 different measures to determine beneficiaries' care satisfaction. How happy are they with the care they're receiving? These are people on Medicare. Members' biggest complaints were around the narrow provider networks they were allowed under the program. Medicare Advantage, this is a quote from one of the researchers, co-author 𝐬𝐭𝐮𝐝𝐲, assistant professor at Drexel University, said members' biggest complaints were around their narrow provider networks that they are allowed. Medicare Advantage penetration is increasing over time. That means more beneficiaries are being exposed to Medicare Advantage plans. But if Medicare Advantage plans are providing limited access care, this will provide negative impacts on the enrollees. Yes, as the number of enrollees increases, Dr. Park, whatever, worries that Medicare Advantage plans may be limiting access to care for those who live outside the city center. Almost said city slickers. Rural residents with poor health status and high health needs are particularly likely to switch out of Medicare Advantage. Now, why is that? You live away from the city. You have less hospital choices. You have less primary care doctor choices. You have certainly less specialist choices. And Medicare Advantage networks tend to capitate their doctors, which means they pay per member per month. So if you live out in the wilderness somewhere and there are not that many people, obviously the doctors are less likely to join that network, which pays per member per month. Nearly 12% of rural Medicare Advantage members who said that they had poor health switched back to original Medicare, compared to just 6% of enrollees with similar health status in non-rural areas. Those who required costly services, and that's what insurance is for. Insurance is for the worst case scenario. As I continue to remind my great clients, people don't get healthier and younger as they progress in the digital age. As they're getting older in the digits of their age, things tend to break down. That's when the warranty on your knee and your hip and everything else and your back starts to break down. So as we're getting to those older ages, this is when we start to insure against the financial losses of high medical claims like this. Those who required costly services like facility or inpatient hospital stays were also more likely to disenroll. 16.8% of rural beneficiaries who stayed in healthcare facilities switched back to traditional Medicare. And 15.1% of rural individuals who required an in-person hospital visit left Medicare Advantage. So 15.1% of the people who realized what happens when they actually go in the hospital and have to rely on a network of providers in a Medicare Advantage network, they got out of the hospital and they left that plan. While rural individuals reported being satisfied with their quality and cost of care, most said they were unsatisfied with their access to nearby care facilities. 20% of rural individuals who complained about the ease of accessing a doctor near their home disenrolled, while only 4% of non-rural individuals who shared the same concern left their program. It says 19% of rural enrollees switched to traditional Medicare over frustrations about receiving all their medical needs at one facility. Yeah, a lot more things like that are happening with Medicare Advantage, where you have to go to one place to get everything done. Because most Medicare enrollees' complaints stemmed from their ability to access care, or their inability, the report recommends that CMS, Center for Medicare and Medicaid Services, implement a more stringent network adequacy standard for rural counties in a plan's service area, or develop policies to incentivize healthcare workers to practice in rural areas. More money for Medicare Advantage is what they're saying. And it concludes here by saying, Medicare Advantage, this is a quote from the doctor, Medicare Advantage plans are kind of like private plans. Well, they are, doc. So unless they have some kind of financial incentive, that's why they exist. They're private plans. They are unlikely to change their practice. That means policymakers should think about how to change their behavior by providing financial incentives to expand their provider network. More money, more money, more money out of Medicare into the private Medicare plans is what they're recommending. So, as I started by saying, there's not one plan that suits absolutely everybody. We have to be sensitive, and that's what we do in my office. We listen to people first to see how often do they access care. How long did your parents live for? How many times a year have you been going to the doctor? How many medications do you take? These are things that we have to take into consideration before prescribing a recommendation of a plan. And also, that recommendation of a plan, if you get on a Medicare Advantage plan when you're turning 65, does not mean that forever and all time you have to stay on that Medicare Advantage plan. Every year there are 2 opportunities to go back to original Medicare. One is during the annual enrollment period. That is October 15th through December 7th of every single year. During that period of time, whatever you choose goes into effect on January the next year. The second period of time is from January 1 to March 31. That's the disenrollment period for Medicare Advantage that they now call open enrollment, even though it's not open. During this second period, or first period of the new calendar year, this is the second consecutive opportunity to get out of Medicare Advantage. So we have a whole process if you're considering leaving Medicare Advantage and going back to original Medicare that you should really, really consider first. Don't just say, you know what, I want to cancel my Medicare Advantage plan. The sad reality is, if some of these things have happened and only 15% of the people pulled the trigger after they experienced what the Medicare Advantage plan was like with a lack of a network. But if you just pull the trigger, you pull the ejection seat, you're out of that Medicare Advantage plan, and you want to go back to original Medicare, only under certain circumstances and in certain locations can you do it without evidence of insurability, which means we have to ask these health questions. And whether you get an agent like me or my office to ask you those health questions to see what you would qualify for, or you go directly to an insurance company and they have one of me in there too, a licensed agent that asks you the health questions to see if you qualify for something. Either way, if you find out you got rid of your Medicare Advantage plan and you can't qualify for a Medicare supplement, there's a real big problem there. Sometimes we find that it's better for a person to go from their HMO restrictive limitation on network plan, like a lot of these people are talking about. That's their biggest complaint, especially outside the city. They could instead sign up for a plan that does give a little bit more flexibility. The costs are higher if you go out of network. Like on an HMO plan, Medicare Advantage, there is no out-of-network option. Unless it's an emergency until you're stabilized, then you better get yourself into a network facility. But there are plans like a PPO plan where you have an option to go out of the network. So you're not just cut off cold turkey and it's like our way or the highway. At least that plan, the PPO plan, if it's available in your area, is better than no plan at all. And original Medicare, remember, is great insurance. Original Medicare, not Advantage. Original Medicare is great insurance, where on original Medicare, That's the benefit that you earn from working more than 40 quarters in your life. That allows you to go to any doctor, any facility, and any hospital in the country that accepts Medicare. That's pretty much everybody. Whereas with Medicare Advantage, you've got the limitations and the restrictions on their network. So one other thing I want to bring to your attention, because this also came out first part of March 2021, it says, if protections expire, the COVID patients could soon be facing big medical bills. Let's look at this article that just came out from Health Day today, and it says, older Americans on a Medicare Advantage plan could face hospital bills of $1,000 or more. I don't know many that are just $1,000. If private insurers start charging out-of-pocket costs for life-saving COVID-19 care, a new study warns. Cost data shows that Medicare Advantage patients pay an average of $987 out of pocket when they're hospitalized with just the regular seasonal flu. And 3% pay more than $2,500, according to this report. To put that in perspective, 2 out of every 5 Americans lack the savings to pay for even a $400 emergency. So here we're talking about just a regular flu, $1,000. Some people paying over $2,500 with Medicare Advantage. And that's if you go into a hospital that is in the network. If you go outside the network and it's not an emergency, on an HMO plan with Medicare, they're paying zero. You're paying 100% full freight. Because remember also, when you are on Medicare Advantage, it's like you're leasing a health plan. You don't own it, you lease it. And the benefits that you sign up for on Medicare Advantage last for 1 calendar year. At the end of that calendar year, they can change that plan 9 ways to Sunday. They can change the drug copays, the hospital networks, the doctors, the copays, the formulary, the benefits, the summary, everything can be changed every single year on Medicare Advantage. They're always tinkering with those plans. Medicare never changes. Medicare supplements don't change if you buy that plan. So a Medicare supplement is very much, it's an indemnity type product that's very much like life insurance. If you buy a life insurance policy when you're 25 years old, the terms under which you purchase that contract will never change. They just can't change. Similarly, a Medicare supplement plan, 20 years ago, you could buy a Medicare supplement plan J. 2 years ago, you could buy a Medicare supplement plan F if you're new to Medicare. Even though you can't purchase those plans anymore if you're new to Medicare, the terms and conditions and the benefits under which those plans were constructed can never be changed. They're not like a ever vacillating Medicare Advantage plan. The supplements are locked in. I don't know why I got on that tangent. So it talks about billing related to flu hospitalizations provides a good notion of what might await seniors treated for severe COVID-19 if insurers decide to change their mind and start charging out-of-pocket costs, because they've been waiving that now. Medicare Advantage plans have a medical loss ratio requirement that they must spend so much of the money that the government is giving to them. Most of the plans are now reporting, as we're almost all the way through the COVID crisis, they did not spend much money on people during the COVID crisis. That's why they're waiving copays. That's why they're waiving telemedicine. That's why they're waiving all these things, because they have to spend money. Some are sending out care packages to their people. Why? Because they have to spend the money. It's already taxpayer money spent. Influenza predominantly affects the elderly and often requires the same type of care as COVID-19. It's the closest analog we have, analogy. Nearly 1.7 million COVID-19 hospitalizations have occurred during the last year, and coronavirus tends to hit older people harder than other groups. We've covered that before. A man on a Medicare, or was it no Medicare at all, had a $1 million, it was a Medicare Advantage guy, bill for over $1 million. All of it waived due to Congress and the plan stepping in and saying, because it's COVID, we're not going to charge anything. But that's what this story is talking about. Those waivers, due to COVID itself being an emergency, are going away. So we're going to go back to the original plan. And that man that I just talked about with $1 million bill was out of his network. That's why it's all on you. So that's what I started with the tangent a minute ago. If you're on Medicare Advantage and then you find out that things are not covered, like you go to an out-of-network hospital and it was not an emergency, original Medicare is not there to back you up. Original Medicare, because you're leasing your plan, you've put original Medicare on the shelf. So the benefits and the rights and the deductibles and the co-payments and all that stuff and the freedom of original Medicare does not just sit there and wait in lieu of your Advantage plan. It's one or the other. A lot of people don't recognize that. That's why when you join a Medicare Advantage plan, they say, put your red, white, and blue card away somewhere. because you can't use both. Use the Medicare card until you get a Medicare Advantage plan, and then that is your card. Those people determine what you get paid and what you don't, not Medicare anymore. So it says about a third of the people now subscribe to Medicare Advantage plan rather than original Medicare, according to Kaiser Family Foundation. There's no federal legislation requiring health insurance to waive COVID-19 treatment costs. They have chosen to do that on their own, but it's not clear how long those waivers will remain. Quote, recently, some of the insurers have begun to walk back some of those waivers, raising the possibility that patients who are hospitalized for COVID-19 might not just have to deal with the physical and emotional toll. That's what we say in every conversation about this. You don't have to worry about just getting better. Then you have to worry about the huge cost of what your plan is going to charge you. Back to the quote, Chua said, but also face a financial dilemma afterwards on Medicare Advantage. Go figure. To get some idea of potential cost to older Americans if these waivers end, Chua and his colleagues analyzed data from more than 14,000 influenza hospitalizations covered by Medicare Advantage. Their findings were published online February 17th in the American Journal of Preventive Medicine. Flu patients faced higher cost-sharing expenses if they needed intensive care or had a longer hospital stay, both of which are common for severe COVID-19 patients. People also paid more if they were enrolled in a preferred provider organization plan versus an HMO. Talking about that just a minute ago. HMO is only good if you're going inside the network. A PPO type of Medicare Advantage plan, it's a different type of Medicare Advantage plan. At least it gives you an option of going outside of a network, but you pay a lot more. So in 2021, the maximum out of pocket for a Medicare Advantage plan can be $7,550. That's the ceiling. Last year it was $6,700. Before that was $5,000 something. Before that was $3,700. Now it's $7,550. That's the stop loss that you have on Medicare Advantage. But that only protects you until December 31st, because every year all those things can change once again. So if you go out of network, the maximum out of pocket is $10,000. So that's what you could potentially face if you're being treated for something as significant as the flu, which is common, or COVID. You're in the hospital, out of your network, and you have a plan that at least gives you some kind of coverage outside your network, like a PPO plan would do. Federal regulators should keep these costs in mind as insurance companies start to rethink their position on COVID-19 care waivers, they said. The U.S. Center for Medicare and Medicaid Services might be able to unilaterally require insurers to maintain these waivers, but the lobby in the insurance world is not going to let that happen. So earlier legislation related to COVID-19 has contained similar provisions, though none have been enacted. Yeah, that's a pipe dream. It really is. In the meantime, seniors should check their Medicare Advantage plan to make sure that COVID-19 costs are still waived. You can't find that in writing on the plan, so I'm not sure where you would check. And appeal any charges that they don't think are warranted. Medicare.gov today in their press room released new guidance on filing Medicare Advantage appeals. So Medicare Advantage is again done by the private world, the private insurance world. But when you have a problem, first you appeal to the plan. And as you go up different layers of appeals, up to 5 layers, you have to go outside of the Medicare Advantage world and complain to mommy and daddy CMS, because they're the ones that are supposed to hold the health plan accountable. The problem is if you get denied care or referral or prior authorization to go get surgery or get something done, you often have to wait 60 days, 30 days, 30 days, 60 days, 30 days, go up to an administrative law judge, all these people at Medicare to finally come back down and say, yes, you should have had this surgery done. Well, guess what? I've been in agonizing pain, told, no, I can't have this done because I'm on this particular plan, and they're trying to save money, which is why the plan exists in the first place. We have a study. If you've not yet seen it on our channel, I'll link it up there, if you can see it. And it's about the Office of Inspector General of Health and Human Services over CMS. And they looked into the fact that 74% of appeals on Medicare Advantage are overturned. So if that huge number of appeals are ultimately overturned, why deny that care in the first place if it's not just about money? So that study talked about people are unsatisfied when they're not in a city-dwelling environment and the hospitals, doctors, and specialists are not swarming around like city slickers. They're out in the country area. And then we have this as a study coming out showing, and this is from 𝐬𝐭𝐮𝐝𝐲, medical doctor and PhD, assistant professor, University of Michigan Medical School, Ann Arbor. And they're looking at the costs that are going to come into play again with Medicare Advantage. As the COVID crisis goes away, the insurance companies get back into the profit mode, because again, they've been benefiting from the fact that people are not having elective surgeries. And I say by elective, they're having their knees replaced, finally getting them fixed, joint repairs, preventive medicine. They're not having the routine tests that they should have been doing, the heart test, the stress test, all those kind of things. They're not having all those things done. So the health plans have been saving a lot of money. So what's going to happen when they get back into profit mode? They're spending their own money from the government on actual medical care now. And so they're going to pull away some of these protections that they've been putting in there out of the goodness of their own heart from having these zero cost associated with COVID treatment from 2020 into 2021. As always, when things happen with Medicare, when things change and things develop and opportunities present themselves, you'll find it on this channel first. I highly encourage you to subscribe to this channel. Most people that watch it are not subscribed. Just hit the little subscribe button, and while you're there, can you smash that like button? I don't know why people say smash it, but if you can hit the like button, that'll really help. And tell me what you think about these kind of limitations on the network with regard to Medicare Advantage. Everybody has a plan that's best for them. And I'm not purporting to tell you here that Medicare, original Medicare with the Medicare supplement is the best thing for everybody. After you've been in this business for a few years, you start hearing stories from other people. You start hearing their experiences and living through their horror stories vicariously. And you can either do one of two things when you hear stories like that. You can either close your ears to it, put your head down, and write business that's going to pay you the most and be the most profitable for you and your business and your agency and everything else. Or you can listen to the people that are actually using the things that you sell. That's what I do. My office listens to our people on the phone. We listen to the stories that they bring us from other experiences that they've had in the insurance world and Medicare. And I've done that for 12 years. So when I tell you something, it comes from a heart of trying to care for more people and give them the truth and give them both sides of the coin. We'll tell you all about Medicare Advantage plans, but if you're going to get on one, we prefer you have one that has a less restrictive network requirement than just a pure HMO, if it exists. So PPO would be much better. If you're going to do a Medicare Advantage plan, that's our option. If you're on Medicare Advantage and you want to go back to a Medicare supplement, you have to do it in order. We talk about that on my website, what that precise order is, because if you get out of that order, you may be stuck with absolutely no care, and we don't want that to happen. So take a look at all your options. We're always here to help. My name is Christopher Westphal. I'm an unbiased, unaffiliated, non-captive, non-company owned, independent Medicare insurance broker. God bless you. Thanks so much for watching. Again, comment down below and tell me what you thought about this video and others. Do you think I'm too far whacked on one side, too far drama on the other side, or right in the middle because we're just bringing you the news that just happened today? Take care, y'all. Thanks so much for watching.